favorite professors, Dr. Ramachandra Mohan, and she knows why we call her the most favorite at any part of the day. You call her for anything related to pediatrics or something to do with the board. Oh my God, she does all kinds of help, whatever is possible, and she'll see that it is completed. Thank you so much, ma'am, for that, first of all. She is the Director and Professor of Pediatrics, Institute of Social Pediatrics, Stanley Medical College. She's done her MBBS, DCH, MD, DIPNB, PhD, and PG Diploma, PG Epidemiology, FIAMS. I think she's got a whole list. Her teaching experience is about 2.5 decades. She's a PhD guide in our university. She has done her original research in COD bilirubin level. She's a member of many societies. She holds many prestigious posts. She has a chapter on visual impairment in the Indian Pediatrics Book of Differential Diagnosis. Today, her topic is severe acute malnutrition, a medico-social malady. She's our speaker, and for discussion we have Dr. TNMGR, Associate Professor of Pediatrics, Government Vellore Medical College, and Dakshayini, Associate Professor of Pediatrics, Nagapatnam Medical College. Ma'am, you can continue with your talk, after which these two people can just pool in and tell their views, and then we'll take it to the forum for if they have any questions, ma'am. Over to you. Yes, ma'am. You can share your slides in case you have them.
Yeah, I haven't got a permission to share.
Ma'am, கீழே நீங்க ஷேர் போடுங்க.
இல்ல ஷேர் போட்டா make sure you have allowed permission அப்படின்னு வருது.
மேம் நீங்களே தானே allow பண்ணணும்.
நீங்க தானே allow பண்ணணும்.
ஏய் இந்த இடத்துல அந்த ஷேர் வீடியோ வரும்ல.
Or you'll have to make me a host, I think.
Can you make her a co-host? Yes, ma'am. 1 minute, 1 minute. Yes, ma'am. Can you try now?
Still, I don't get permission to share. It still says the same thing.
Ma'am, you do one thing. Just share your slides through Gmail to our TNMGRMU.ac.in.
Make sure you're allowed permission to share content. அப்படின்னா வருது. I have not been given sharing permission.
இல்ல அவங்க ஹோஸ்ட் இல்லையே. இப்ப co-hostனா உங்களுக்கு ஒன்றும் ப்ராப்ளம் இருக்காதுல்ல?
Co-host ஆக்குனா தான் 1 minute. Let me see if I can.
Ma'am, you log out and come back again now once more.
Okay.
Ma'am, நீங்க ஒரு மெயில் அனுப்புங்க உங்களோட ஸ்லைட்ஸ்.
Slides, okay.
Ma'am, she's just telling you the mail address. TNMG.
But kindly send it to TNMGRMU tnmgrmu.ac.in.
TNMGRMU at
TNMGRMU.ac.in.
TNMGRMU at இல்லையா?
அதான் மேடம் at
ஆ.
TNMGRMU at again TNMGRMU.ac.in.
ஓஹோ, TNMGRMU.ac.in. வந்துடுச்சா? வந்துடுச்சா?
Can you try sharing it now, ma'am? Because the icon on your screen shows that you are the
No,
presenter.
it keeps telling that I have not got permission to share. They have to give me
But the
permission to
icon-
share. I don't know why it is. The same thing is coming. Make sure you have allowed permission to share content and try again அப்படின்ட்டு தான் வருது.
Okay, ma'am.
I don't know what other settings can be
Share.
changed for that.
Icon is also seen.
சொல்லுங்க. Okay. Yeah, why you're not giving me permission?
Here also is showing you co-host, but I really don't know what next you're supposed to do. Permission from our side is given. Something is going wrong.
Yeah, then what is happening? Why does it come that? Because first thing I did was I came and I started sharing my slides, so I thought it will be open by the time the meeting starts. Apathilarundu it says you are not got permission. You are not got permission.
Huh?
Ma'am, can you be made the co-host, ma'am?
பண்ணிட்டோமேமா
இல்ல ma'am, co-hostனு வரல. மேடமோட நேம்க்கு கீழ it doesn't show that.
சரி மேம் நீங்க எனக்கு மெயில் அனுப்புங்களேன் அந்த TNMGR சங்கீதா அனுப்ப மெயில்ல.
Slides யா?
ஆமா ஸ்லைட்ஸ்
Ma'am, now you are the co-host.
Okay, let me try now.
Yeah, ma'am.
Got to mail. Vandiruchu. Mail has come.
Mail has come.
Yeah, we'll
Let me
share
also
now.
try.
Madam, we will share. We will share.
1 minute, let me just see. இல்ல இன்னும் பெர்மிஷன் கொடுக்க மாட்டேங்கிறாங்க யூனிவர்சிட்டியில எனக்கு.
ஒருத்தர் உட்காந்துட்டார் பாவம் அவருக்கு தெரியல.
சரி ஸ்டார்ட் பண்ணிட்டீங்கன்னா இல்ல
சரி ஷேர் பண்ணுங்க. ஷேர் பண்ணிட்டோம். ஷேர் பண்றோம். அம்மா மேல செல்போன் பார்த்துட்டு இருக்கேன். ஸ்டாப் வீடியோவா? ஸ்டார்ட் வீடியோ ஷேர் போடுதா? ஓகே.
நான் அங்கேயே வந்து பிரசன்ட் பண்ணிருப்பேன்.
அதான் பெட்டு நாங்களும் பாரு டென்ஷன் இல்லாம இருந்திருப்போம் மேம். இது என்னது? What is that? Share. Please. Yes, ma'am. Finally.
Okay. Okay, fine.
Very sorry, ma'am.
Okay, can everybody see the few people who have logged in? First of all, I'm extremely thankful to the Tamil Nadu Dr. M.G.R. University. Can previous slide?
Previous slide.
Previous slide. நான் சொன்ன ஒரே மாத்தாதீங்கம்மா please. Yeah. So I'm thankful to the Tamil Nadu Dr. M.G.R. Medical University for giving us an opportunity to talk about a topic. They wanted something to do with social pediatrics, and I think this is the right topic to have chosen and to have given us a chance to discuss about. எனக்கு வந்து please, yeah, I have some people to thank. So I thank Dr. Dakshani and Dr. Tenmuri at the outset, my assistant professors who immediately have consented to be part of this panel. And so let's go on to the next slide. So our the great poet Subramanya Bharatiyar has said that Tani oru manidhanukku unavile enil jagathine azhithiduvom. So that's the importance of meeting hunger with food. So nobody on earth should go without food. So that's the importance of managing hunger. Next slide. So what do we mean by malnutrition? So we always think that malnutrition is undernutrition resulting from either reduced intake or inadequate absorption or excessive loss of nutrients due to other causes. But it also includes overnutrition, okay, because there is, which is also becoming a problem now. Next. But my talk is going to be limited to only undernutrition. So previous slide. So when I say undernutrition, it means wasting. Wasting is low weight for the height, stunting is low height for age, and underweight is low weight for age. So we'll discuss these terms in a little while. And there can also be micronutrient related malnutrition. So it can be specific micronutrient deficiencies like vitamin E deficiency causing rickets or iron deficiency causing anemia. and other conditions, which again we'll be talking about, overweight and obesity also. Next slide. So looking at the trends, levels and trends in child malnutrition, so we are not the only country having our own problems. There are a lot of other countries also. So when you look at wasting, 45.4 million children are found to have appears to be wasting. And among stunting, there is 149.2 million, a whopping number, and overweight also is 38.9 million. This is the key findings of the 2021 edition of the UNICEF regions. Next slide. So what do we mean by stunting? It's a child who's too short for his or her age. So that means the undernutrition has been there for a sufficient time to prevent this child from reaching his potential. So these children can suffer from irreversible physical and cognitive damage, and the devastating effects of this stunting can last a lifetime. And because this child can beget small children, it can even affect the next generation. Next slide. So when you look at the prevalence of stunting by country and the UNICEF sub-region, you can make out that India is about more than contributing to more than 30%, which is very high. So India, the sub-Saharan countries, Southeast Asian countries, they all contribute to the majority of stunted children. Next. So wasting is a child who's too thin for his or her height. So when you say wasting, it is usually an acute malnutrition. So recently, rapid weight loss or failure to gain weight after the child has fallen sick. This child is also at an increased risk of death, but this can be treated. So that's something happening acutely. So treatment is possible and this child can be brought back to normal. Next slide. So let us look at the wasting. What are the countries which are having children who are wasted? So here again, you see that India is again somewhere at the top, more than 15%. And this is, of course, distributed among the different countries. Next slide. Yeah. No, overweight, it's a passing mention because it comes under this parameters. Here is a child who's too heavy for his or her height. This is because of increased energy intake, both from food and beverages, which exceed the child's energy requirement. And what is the problem in overweight? It looks very nice to have chubby children, but it is laying the foundation for non-communicable diseases later in life. So even this is a malady in itself. Next slide. So here you see, this is the only one where we are a little low. So here ours is only less than 2.5%, whereas you have it being pretty high in the other countries. So if you see Africa, even here, this is significantly high. Next. So if you see the global overview, are we, by improving the nutrition programs, improving accessibility to food, we have found that stunting has steadily declined since 2000. But if you want it to come down here so that it can meet the SDG goals by 2030, then we have to go a little bit faster. And wasting, on the other hand, is just remaining there itself. Okay, it is persisting at an alarming rate, and overweight will have to require a reversal is needed for it to come back to its normal level. Next. So what is our target? Our target is by 2025 to reduce the number of under 5 children who are stunted by 40%. And by 2030, it should be reduced by 50%. Wasting should be reduced to less than 5% by 2025 and 3% by 2030. And see that there is no increase in child overweight prevalence both by 2025, and try to reduce and maintain it to less than 3%. Next slide. So how are we? Are we on track? There are very few countries. Only about half of the world's children live in countries which are on track. The remaining are off track. So we may not be able to meet the 2030 targets on child malnutrition, which is a very, very worrying fact. Next. So 3 regions, we know that Africa and Asia is bearing the brunt. Majority, 9 out of 10 children are stunted, wasted, and about 2/3 of them are overweight. Next. So this is how we have, there's a graph showing that in high income countries, the overweight population is going up, and in the low income countries, stunting and wasting is still slowly coming down, but not at the rate that we would like to see. Next. So there's something called a global hunger index, which is a tool designed to comprehensively measure and track hunger at the global levels. The International Food Policy Institute is scoring each year to see how well we are doing as far as a global hunger index is rated. So next, it is based on the next slide. It is based on 4 things, that is the undernutrition, child wasting, stunting, and child mortality. So based on these 4, they come up with a hunger index 2021. Next slide, please. So how are we faring? So we are doing fairly good progress. From 38.8, it has come down to 27.5. So please go on to the next slide. So this slide will tell us where we actually stay. Okay. Sorry, we were here. We were at 38.8, and now we have come down from an alarming situation. We have come down to a serious situation. We have a lot of homework to do in order to come to moderate or low levels. So we are nearly 101 out of 100. Our rank is 101 out of 116 countries, with Sri Lanka, Bangladesh, and even Pakistan doing better than us. Next slide, please. So these are the NFHS latest, figures, and we have about nearly 40% children are stunted in India, about nearly 30% in Tamil Nadu, wasted is nearly 20%, and those who are severely wasted are nearly 8%, and those who are underweight is about 25%. Next slide. Okay, next slide. Next slide. So now I'm going to come back to my topic, which we are going to concentrate on today, is severe acute malnutrition. So this is not a diagnosis which is made at the lab level or any investigations, but it is totally a clinical diagnosis. So when the child's weight is very low, so weight for height or length is less than -3 standard deviations, then we call it a severe acute malnutrition. Or if the mid-arm circumference is less than 115 millimeters or 11.5 centimeters, or if there is a presence of nutritional edema. So when these three, one of these is there, we call it a severe acute malnutrition. Next slide. So there's some other term called moderate acute malnutrition, which is in between undernutrition and severe acute malnutrition. And here this mid-arm circumference will be between 11.5 and 12.5. And instead of the weight for height being less than -3, it is less than -2 standard deviations. And global acute malnutrition is the sum of the prevalence of acute malnutrition plus moderate. It's at a community level. Next slide. So what causes severe acute malnutrition? So here is my title, which says that severe acute malnutrition is both a medical and a social disorder. And whom does it affect? Those who are not having the privilege of exclusive breastfeeds, who have not been introduced to complementary feeds at the right time, who are given diluted feeds which do not have adequate nutrients, who are repeatedly suffering from infections either of the gut or of the respiratory tract, whose parents do not have the knowledge to give ideal diet, or do they have the knowledge but they do not have the money to provide good food to the children. So these are the children who will suffer from severe acute malnutrition. Next slide. So as I told you, it is a clinical diagnosis. So who should make the diagnosis is not always a pediatrician who's going to be available in the community. So it is something which is done by the ICDS workers, done by the field workers, VHNs. So the diagnosis is done at the community level. So then where is the problem? It is not being assessed properly. That's the first major problem, that it is not being, first of all, whether it's being recorded or not. If it is recorded, whether it is recorded properly. If it is recorded properly, whether it is plotted on an ideal growth chart, which will tell us whether this child is coming below -3 standard deviations or not. Once it is being done, is it being referred? So these are the 4 gaps that we see in the management of severe acute malnutrition. So we are going to look at 3 anthropometric indices: weight for age, height or length for age, weight for height or length. So we'll quickly see how to do the anthropometry. I thought I'll spend a couple of minutes on this particular aspect because This is the most important step in severe acute malnutrition, is to picking up these cases. Next slide. So the first thing that we do is measure a length or the height of a child. So it's all pediatricians know that if the child is less than 2 years, we measure the length. If the child is more than 2 years and able to stand, we have to measure the standing height. So what if a child is less than 2 years, but you're not able to make the child lie down, due to different reasons? Then you make the child stand. But we know that when the child stands, we are not able to keep the child straight. The child will be bent at the knee. The child may not be is whole stretched length. So for that, we have to add 0.7 centimeters. What if a child is aged 2 years and older, but he cannot stand? In that case, you measure the recumbent length and you subtract 0.7 centimeters from that. Next slide. So when it is coming to measuring a height or the length of a child, for the height, we have to go down to the child's level so that you can actually see this level at the eyes. But for measuring the length, definitely two people are needed. It cannot be done by a single person. So I always tell the mother to hold the head. Okay, mother holds the head. The child knows that nothing dangerous is happening. The child cannot see what is happening at its lower end, so the child can start crying. So when the mother holds the head tightly, then we can get the exact measurement of the length. Next slide. So when it comes to weight, we have weighing machines which are digital these days, and up to 0.01 kgs, 10 grams also we can measure. But there is something called a tarred weighing. In that case, what happens is the scale can be reset. So supposing the mother and the child are standing on the scale, or the mother is standing on the scale, you can reset it to 0. Thus the mother can stand, be weighed, and the scale is tarred. While remaining on the scale, if you give her child, the child's weight alone appears on the scale. So this, I'm not sure if it is available here, but this will be a big blessing for us so that we can get an accurate measurement of the weight. Next slide. Mid-arm circumference. So most of this field workers are dependent on this, and lot of community-based programs usually use this mid-arm circumference. So less than 11.5 centimeters, they should be known to refer the child immediately. And so we do it from newborn. So earlier we were doing it only from 1 year or so. Now we are doing it from newborn. For a newborn, the average mid-arm circumference will be around 9 centimeters. We can use it up to 5 years. So how do we measure? The arm circumference is measured on the upper left arm, and first you make the next slide, make the to locate the correct point. Next slide, please. First, the child's elbow should be bent at 90 degrees. Then you find a midpoint between the shoulder and the tip of the elbow. You mark the midpoint. Then you allow the child's arm to hang freely towards the thigh, and then you place the measuring tape around the arm. So the tape should not be pulled too tightly. Next slide. Yeah, so this is the way. So first you bend it, mark a point between these two. Once you have found the point, the child's hand should be left loose. Then you measure it at the point that you have found. So now there is an easier way of doing it. Next slide. So this is for a field worker. Supposing the field worker cannot read numbers, some of them are quite old, they refuse to wear specs, they cannot see numbers. So they will think that the child is normal and send the child away. So we can use a colored tape. So if it is green, this child has got no acute malnutrition. If it is yellow, there is moderate. And if it is in the red, it is severe acute malnutrition. So 2 times you repeat it so that you make sure you have a correct interpretation. So this is how it is measured. Next slide. Next slide. So now we know that this child has been referred. So supposing this child has been referred to you from the community. Next slide. So now our job is to find out the reason why this child is having malnutrition. So we know that we said that it could be due to several factors, starting from intake to the digestion to the assimilation or enteric infections, anything. So quickly we should get the history of what this child has been eating. Okay, a recent intake of food, fluids, what is it? Supposing the child has come for illness, what was the child taking before that? Breastfeeding, whether it was exclusively started, whether it was still being given, and all that we get. Then whether this particular illness, if the child has come for, what is the frequency of diarrhea, vomiting, what's the type of diarrhea, type of cough, what is her appetite like, how is the child's circumstances. Social history is very, very important for malnutrition. Whether there is a history of contact with tuberculosis or measles, we should remember that post measles is one big trigger factor for setting off a child's malnutrition. Then suspected or known HIV infection, that's also very, very important. And then the history of immunization. This is just an overview. There are a lot of other histories that we will ask, like worm infestation and all that, but that is not as important as this. Next, we'll go on to the next slide. So quickly, so this child has come. Now our job is to find out whether the child is sick or not, whether the child needs emergency care or outpatient care or just a ward care. So these are things. So pulse or heart rate we quickly measure, respiratory rate we count, then measure the temperature of the child. These children are highly prone to going for hypothermia, which is a temperature of less than 35 degree centigrade or 95-degree Fahrenheit. Look for signs of dehydration. See whether this child's arms are cold, slow capillary refill, or a thready pulse. Next slide. Then we come to the head to foot examination. So we know that most of these severe acute malnutrition children, so agathin alagu mugathil theriyum, so whatever is inside, whatever undernutrition is there is shown on the child's hair, in the eyes, in the skin. So the child's hair will not be lustrous like the child who's having a good nutrition. Okay, so all the micronutrients are needed for even to have good hair. The child can have loss of hair in patches, can have hypopigmented hair, and the hair may not even be growing properly. So all those things are eye changes. So we look for vitamin A deficiency, look at the ear, look at the throat, see whether any infection anywhere, look for any oral ulcers, look at the palm and compare it to your palm if you are having a normal hemoglobin, and see whether there is anemia or not. So skin changes of kwashiorkor, we don't see those changes much nowadays, thankfully, but there can be patches of hypo or hyperpigmentation, desquamation, ulceration, exudative lesions, all that can be there. Okay, next slide. Yeah, so these are some of the changes that we see. As I have told you, we are really thankful that we don't see such extensive skin lesions anymore. As a postgraduate, we have seen these children so often, and it is very sad to think that just some good nutrition would have made these children all right. Of course, there are a lot of other problems also in some of these children. These are all the eye changes that we have to look for. Next slide. Then you have, that's not enough. From outside we have seen, inside go and see what is the reason for the malnutrition. So look whether there is any infections like pneumonia or any congenital heart disease, any neurological involvement, any disorders like cerebral palsy where child cannot even eat properly, or any spinal muscular atrophy, things where the child cannot swallow, GI disorders, renal conditions. We'll have to quickly examine all these children. Subsequently, if you find that one of these systems is involved, then it goes to a different trajectory. The child will need investigations and all that for treatment. Next. So when will I decide on admitting this child? If the child is having any emergency signs, which I'm going to tell you in the next slide, if there is edema, persistent vomiting, the child is very weak and apathetic, and having fever or hypothermia, this child will definitely have to be admitted. Next slide. Like children with fast breathing, extensive lesions, diarrhea, anemia, or hypothermia, as I told you. Next slide. So when it comes, previous slide for a second, please, previous slide. Yeah, so just remember three values. If the child is up to 2 months, which is just beyond the neonatal period, a rate of more than 60 is significant. 50 is up to anything more than 50 in children up to 2 years from, up to 1 year from 2 months, and more than 40. So these values we should remember by heart, so that we will know whether this child is having fast breathing or not. Fast breathing is definitely a sign of a sick child. Next slide. Next slide. So here again, we have to remember the emergency treatment, airway, breathing, circulation, and look for dehydration. Next slide. So as I told you, look at the respiratory rate, and not only that, look whether the child is having any chest indrawing. See whether any accessory muscles are being overused. The child is not able to feed because of severe distress, or there is a stridor when the child is quiet. Next slide. These are all emergency signs. So whether the child's hands are cold or warm, look at the capillary refill time, whether it is longer than 3 seconds. Is the child's pulse weak or fast? Next slide. Whether this C is for coma and convulsions. So we are going to see if the child is comatose, having lethargy or convulsions. So child is wide awake, we know that we don't have to worry, his sensorium is normal. If the child is sleeping, we have to try to wake the child and see, or call the child. If the child is waking up, then maybe the child is a little lethargic, but if even that is not successful, just apply a firm pressure to the nail bed and give the baby some pain. If the child is still not waking up or even to voice, then we know the child is unconscious. Next slide. So here we have to add the the sign is that of dehydration, and if there is a history of diarrhea, we have to look for dehydration. Next slide. So if the child, so airway, we know this child is not breathing, gasping, and on the other hand may have obstructed breathing, baby is blue, having severe distress, having shock, or any of these signs, this child has to be admitted. Next slide. So I'm not sure I can myself read this. I'm going to skip this slide. Next slide. Yeah, so now we are going to see the management. So we should remember that hypoglycemia will commonly occur within the first 1 or 2 days, hypothermia also around the same time, and dehydration also. The other things will take its own time to act. So I'm going to quickly go through these 10 problems. With that, we will know how to manage a child in the hospital or any facility with SAM. Next slide. So first is hypoglycemia. So again, one more value we have to remember is 54. So if the blood sugar is less than 54, it is considered as hypoglycemia. What if you're in a facility where you do not know, you do not have a glucometer? How will I pick up hypoglycemia? In that case, we have to suspect. So based on certain symptoms, we know if the child is looking lethargic, it could be hypoglycemia. If the child is hypothermic, it is also a sign of hypoglycemia. The child may be very limp, or the child may have lost consciousness. Don't expect sweating and pallor like you see in an adult or an older child, which is very uncommon. So most of the time, if the child is listless, we'll have to think in terms of hypoglycemia in these SAM children. Next slide. So what should I do? So you're checking the blood glucose immediately. I don't have a glucometer, but I'm suspecting that this child is having hypoglycemia. What should I do? Immediately, I'll give the child a 50 ml bolus of 10% glucose. Sucrose may not be available, but you can give glucose. 1 rounded teaspoon of sugar in 3 tablespoons of water. Immediately, we have to give. Okay, my child cannot drink. What should I do? If the child can drink, it's oral. Otherwise, you can give it through the NG tube. Okay, if the child is lethargic or unconscious or convulsing, then what shall I do? Then 5 ml per kg of 10% dextrose, we give it IV, followed by 50 ml. You can start giving oral, because we should always remember that the enteral route is the best. When you give it enterally, then the spread of glucose into the bloodstream is much more steady. Next slide. Next slide. So when you're giving fluids, for previous slide. We should always remember that giving one bolus is not enough, because it can cause rebound hypoglycemia. So whenever we give a bolus, we should always continue to give the baby a maintenance fluid, and at the same time remember to start the child on feeds. So starter diet, which I'll be talking about now, it should be given half an hour after giving glucose, and every half an hour during the first 2 hours it should be given. And as hypoglycemia and hypothermia coexist, make sure that the child is kept warm. Hypoglycemia is a feature of sepsis, so start the child on antibiotics. Next slide. So hypothermia. So we know that once the temperature is less than 35, the rectal temperature is less than 35.5. So what do? I do not have a rectal thermometer. So how will I know how severe the hypothermia? We know that only if it is less than 32, it is called as severe hypothermia. So what should I do? Sometimes you will find that the mercury is not moving beyond a particular level. In that case, we have to think of severe hypothermia. Next slide. So quickly you have to rewarm the child. Okay, quickly rewarm the child. Either put the child on the mother's chest like in kangaroo technique, or use an overhead warmer. Just see that the child is not, we have seen children, because their skin is also so fragile. If the child is put directly on the hot water bottle or directly kept close to the heater, that the child can develop burns. So wrap it in a pad, and then you can warm the child, and keep on recording the temperature every 30 minutes so that the child does not get overheated also. Next. So radiant warmer is the best if the child is a small child. You can put the child there and you can connect the probe to the child's abdomen, and it will automatically increase the child's temperature. And if there is severe hypothermia, we should remember that the thermoregulation is functional only when oxygen and glucose are given to that. So if there is severe hypothermia, even if it is a newborn or an older child, start on warm humidified oxygen, and also start giving the child 5 ml of 10% dextrose IV. If IV line is difficult, you give 10% dextrose by a NG tube, and you start on IV antibiotics. Next. So same thing, but we should only remember that in the severe hypothermia, we should not rapidly rewarm the child, because it can produce a lot of problems in the child. First of all, slowly we have to bring up the temperature to 35. Once a child's temperature is 35, then you can start doing. So oxygen should be warm, IV fluid should be warm. The child should be, whatever you're giving orally also, that also should be warm. Next slide. So third major problem that we are going to see in these children is dehydration. What is the problem in that? We can give fluid, means we cannot assess dehydration in a malnourished child, because this child itself will be will not have subcutaneous fat, and the child will also have sunken eyes and lethargic. So it's very difficult to check for dehydration. Next slide. Yeah, so these are the things that we have to look for. Some mild dehydration, of course, can be treated as outpatient. But if there is some dehydration, this any of the two, child may be just restless, very irritable, having sunken eyes. You give water, the child drinks eagerly, and pinch will go back quickly. So if any of these things are there, there is some dehydration. If the child has severe dehydration, he will be just like he is really sick, lethargic, sunken eyes. He won't even get up to drink water, and you pinch the skin pinch will go back very slowly. Next slide. Next slide. Yeah, so you have to start ORS, and ORS in the we have to give ORS very carefully in a child with SAM, because they are highly prone to develop hypernatremia. So we have ORS which is meant for these children, called as Risomal. So their sodium content is less now. How often will you give? Every 30 minutes for the first 2 hours, 5 ml per kg. After that, for up to 10 hours, alternate hours, we can give 5 to 10 ml per kg. Next slide. Next slide. So what is very important, starting IV fluids is not a solution. We have to see that the child is not overhydrated. Weigh the child in the beginning and see that the child is not getting too much. Mark the liver and see whether the liver size is not rapidly increasing. Also look at the respiratory rate, pulse rate, capillary refill time. Because if the child's heart rate or respiratory is increasing very rapidly, that means we are overloading the child. So best is if the child is able to take orally ORS, then the mother should be taught to give it by spoon slowly. It should not be, the child should not be forced to drink, or put in an NG tube. That also can be used to give the child slowly. But usually NG tube is when the child is vomiting or having fast breathing or mouth sores. We can do that. Next slide. Next slide. I'm not going into the treatment of dehydration. So potassium should be given for this child for at least 2 weeks, because these children will have hypokalemia. That will also add to the weakness of the child. It is given as a syrup. So syrup pot chlor can be given. Maxel, first day alone, it is given as IV. Thereafter, it should be given as orally. Whatever is given IV only is given orally also. For 2 weeks, we have to give. See that we do not give extra sodium alone. Next slide. So infections, we know that these children are highly prone, their immunity is at its very low level. So antibiotics, if there are no complications, it is amoxicillin. Next slide. But if there is complications, any complications which are not very severe, still ampigenta can be given. If there is septic shock, cefatoxim and along with gentamicin is given. If there is meningitis, again cefatoxim, ceftriaxone along with amikacin. And dysentery means we give ciprofloxacin. I'm not going into the doses. Next slide. Next. Duration. So if you're only suspecting sepsis, 7 days. But if it is documented sepsis, if it's UTI 10 up to 10 days, meningitis up to 21 days. If it is HIV positive children, cotrimoxazole prophylaxis can be given. If associated malaria, TB, amoebiasis or HIV should be treated as per guideline. Next slide. Vitamin A supplementation. All of us know that these children, we are talking from the beginning itself, that these children can have vitamin A deficiency. So there is a standard doses of less than 6 months, we give 50,000 international units. 6 to 12 months, we give 1 lakh. More than 12 months, 2 lakh international. Next slide. Other than that, these are all the requirements. We have to continue to give folic acid, zinc, copper, iron. Iron we do not give immediately. After about a few days, once a child is on full feeds, we start giving the child iron. Next slide. So we have come to the later part of our discussion. We finished treating all the complications. Now how to start feeding. Next slide. So we think, okay, this child will be wanting to feed. Let us quickly give. No, we are not supposed to do that. It's a very critical part of managing this condition. Very cautiously, frequent, small amounts we have to give. So the diet itself is called a starter diet. So the initial diet should be contain 75 kilocalories and zero point 0.9 grams of proteins in 100 ml. So it is called as F75. It's low in proteins and sodium and high in carbohydrate, because that only the child will get all the energy he needs. Next. So slowly we start 1 to 2 days every second hourly, and then we slowly increase the amount depending on how. So the frequency becomes a little further down, but the amount will be increased. Next. Next, we come to the catch-up growth. So now we have stabilized the child. We have treated all the infections. The child is able to tolerate feeds. Now we can go to a higher level. So this is called F100 because it contains 100 kilocalories and 2.9 grams of proteins. So that here porridges of modified family foods can be used. Next. So we have to replace that F75 with F100 over 48 hours and increase each feed by 10 ml until the child leaves behind some amount. Then we know that that is a point that the child can consume. Next. So once the child's appetite returns, within 2 to 3 days, you will find that this child's appetite has come back, increase the frequency, increase the amount. If the child is on breastfeeds, he should be allowed to feed as much as he wants. Next. So is that all enough? We have to also provide tender loving care. So how do we do that? See that the child is brought, having a cheerful, stimulating environment, having good structured play therapy, age appropriate physical activity. In those days when we were postgraduates, the children were all nurtured in nutrition rehabilitation centers where these children were given a happy environment away from the stress of whatever the child has been experiencing at home. Even the mother will be here. She'll be taught how to make simple recipes. So instantly we have been granted permission to restart a nutrition rehabilitation center, and we are hoping that we can cater to the number of children who are there around us. Next slide. So now the child should start recovering. If the child primary failure, so the child should start recovering. If the child is not regaining appetite by day 4, not losing edema, even on 10th day, if edema is still there and 5 grams per kg per day, this child is not gaining. Next slide. Then we'll have to find out what is happening. Next slide. So there could be something wrong. So good weight gain means more than 10 grams per kg per day. The child is responding to your treatment. Moderate means at least 5 to 10. Less than 5 means definitely there is poor weight gain. So it could be due to, next slide, some infection, TB. The child, you're not, whatever has been told, the mother has not been giving. Maybe the mother doesn't know how exactly to feed the child, or whatever you're preparing. Maybe it is over dilute. It is not having the adequate nutrients. Next slide. So that has to be looked for. See whether any like iron deficiency is there, can result in the child not gaining weight at all. So if you're giving any preparations, syrups, micronutrients, see that the mother is measuring correctly, giving it. Like iron should not be given with milk. So we have to ensure that it is given in between feeds. So all that we have to see. Only then you will find that the child may improve the way we want. Next slide. Yeah, so go back and see what you're missing. Some urinary tract infection, maybe this we have not taken the culture properly. Maybe the child is having a ear infection, TB, giardiasis. These are all things which can be frequently overlooked. So go back, do a complete blood count again, look at the stools, look at an x-ray. Maybe you're giving the wrong antibiotic also. All that has to be corrected. Next slide. So now we are all ready. The child is also ready. So can I send this child home? Yes. If the child does not have infection, he's taking 120 to 130 kilocalories per day. Yes. Consistently, the child is gaining weight. There is no edema and he's been immunized. And even the people at home are ready to receive and follow your instructions. So that's very important. You should not go back to a very sad environment again. Next slide. So why is that over? Can we tell her, okay, bye and take care of your child? No, to see that at least for the next 3 months they come back regularly for checkup, see that they receive the adequate immunizations, because measles and all that, we said how debilitating it can be. Whether vitamin A is given every 6 months, see, ensure, motivate her to continue to give energy, and it doesn't have to be costly food. So all these, ragi and all that itself will have adequate jaggery and all those things. So diet, and then putting the child in a balwadi will also help the child gain both in knowledge as well as in nutrition. So structured play therapy. Next slide. So I just want to bring to the notice of everybody. I know most of you are aware, but there is something called an ICDS. Okay, that is one of the major programs the government of India has, and it is also one of the largest and unique programs throughout the world for early childhood care and development. Okay, it's one of the foremost programs, started in 1975. Next slide. And who are the beneficiaries? All children less than 0 to 6 years. You try to improve their health status and nutrition through these Anganwadi centers. You're laying the foundation for psychological, physical, and social development. You're reducing school dropout by reducing mortality, morbidity, malnutrition. Coordination of policy and implementation of various departments happens. And also, you're enhancing the capability of the mother to look after her own health and the health of the child. Next slide. Why I'm specifically bringing up this thing is they are getting 50% of the financial assistance from the center, and the remaining is done by the state. Next. This is the major reason why I thought I should talk about ICDS, because it's Poshan Abhiyan, that is the nutrition of a child on the first 1,000 days of life, that is from conception up to 2 years of age, whether the child is getting adequate nutrition. So the child, from the pregnant mother to the lactating stage up to 2 years, these children are followed up. Okay, who does it? It is done by the Anganwadi workers. How do they do it? They're all being given tablets, they've been given, or phones. Here they track a child's weight, so they will plot as soon. That's why I was insisting on the anthropometry. If that person is able to record properly and she documents it on her tracker app in her phone or in her tab, it is documented, it will reach us sooner. Okay, all these data are compiled, so we know how many children are underweight in the community, how many are stunted, how many are obese. All this data is recorded by these people. Next slide. Next slide. It was started, this particular program was started on March 8th, Women's Day in 2018. And the ICDS people tell us that this is the best thing that could have happened to the pediatric fraternity. Next slide. So these are all the strategies and interventions. They are concentrating on feeding, immunization, deworming, giving supplements, how to fortify the food, how to diversify diet, adolescent nutrition, maternal nutrition. All this come under Poshan Abhiyan. Next. So if there is iron deficiency, we know that this is a major problem for us, especially in the adolescent period. Once they attain menarche, we find that a lot of them are going in for iron deficiency, and we are trying the iron supplementation in the adolescent period is sometimes not taken seriously, and these are the girls who are going to give birth to IUGR or preterm babies. Next slide. So there is a Anemia Mukt Bharat. There is another scheme where children are given bi-weekly 20 milligrams of elemental iron. 5 to 9 years they given 45 milligrams, and adolescents they given 60 milligrams of elemental iron. Next slide. Next. They're being biannually dewormed, and they're also being screened. And whenever there is mild anemia, 3 milligrams. Whenever it is severe anemia, they send to us, where we start therapeutic doses of 6 milligrams per kg. Next slide. So these are my sources for this. I wanted it to be general because I did not know who is going to listen to the talk. So it is mainly from the facility-based care of severe acute malnutrition, which is a very good guide for the field workers, and IAP guidelines. And I got my data and all from Dr. Dakshayani, the global and Indian data. I want to thank her also. Next slide. So let's all join together to see that our children are they grow up to their maximum potential, and let not anything come in the way of seeing them blossom and flourish. Let's give them the roots to grow and the wings to fly. Thank you all.
To Dr. Dakshayani and the other panelists as well, so that we can finish and come back to it. Ma'am is joining us from a car. Huh?
Yeah.
Thank you so much, ma'am. That was an impressive talk from an adorable teacher. And I thank the Tamil Nadu M.G.R University for choosing the appropriate topic for the appropriate person. I mean, she can render any talk efficiently, but being the director of social pediatrics, talking on this social malady, which is a very big problem of concern. Having moved to a peripheral part of Tamil Nadu, now I realize how hardly it hits. And appropriate for one more reason, that the National Health Mission, the Government of India and the National Health Mission have started this drive for the next 3 weeks. They've given the directive to assess children below 6 years of age with severe acute malnutrition and MAM, and identify 10% of these children, the children with complications, and to be referred to the district early intervention center. So the RBSK medical officers, and as madam pointed out, the ICDS group of workers are all in full spring. They've started since the last week, and for the next 3 weeks it will go on. So this will be a very big drive in bringing down the under 5 nutrition, which is one of the top 5 causes of mortality in children. So this recording, this would be available because ma'am has put it in such a way that anybody, no, even a non-pediatrician can understand it so well. The method of measuring the mid upper arm circumference and the importance of measuring the weight using the TARS, that element, even this was new to me. So the importance of enteral feeding over parental feeding, all that is really something. These are all small things, but it definitely would reach the periphery better, because we are all scared, like we are not delivering optimum care to these children. And the importance of treating hypoglycemia in the presence of hypothermia, all that was emphasized very well. So thank you, madam. You have again hit the nail on the head, and this is no surprise to us. Thank you, ma'am.
Thank you.
Rama, ma'am, if a
Good afternoon,
pediatrician, ma'am, if a pediatrician says it's so much of value, you can imagine the value that we will have, ma'am. It's really very nice
True.
to.
It will be really helpful if this recording on YouTube would be circulated across in the RBSK and DAC groups, because the drive is going on and it will be there for another 3 weeks, ma'am.
Ma'am, this is already recorded in the YouTube. It is up, and it will remain in the YouTube, ma'am. Especially in our website, you can see it, and I'm sure I hope
circulate to the RBSK museum.
Yes, ma'am. Yes, ma'am. You can do it, ma'am. Thank you, ma'am.
Thank you.
Good afternoon, ma'am. I know madam as a developmental pediatrician, but madam, as nutritionist, she talks a very broad and clear, neat presentation. And what we don't know itself, even we are in a pediatric part for a longer time, so we don't know about the programs. Even the programs, she talked very well about it. And as Dakshayani said and madam said, we can display the videos and displays the PPTs to the RBSK team. But these can be useful for the medical officers, but not for the peripheral workers. The measurement and anthropometries only we can share the peripheral workers. For the medical officers, we can send the treatment and the initial statistics, all those things. And for few things, I want to add the presentation. One thing is complicated SAM and uncomplicated severe acute malnutrition. So with the for complicated SAM, the madam said all the emergency signs. If the baby is having all the emergency signs, you can label it as a complicated SAM. But even the baby is having edema, the child should get admitted and should be referred to the tertiary center for the management. So that should be emphasized in while screening the SAM children. And one more thing, the appetite test. Appetite test can be treated as an OPD itself. And these appetite tests can be done in the RBSK team at the periphery level. So they can use the ready-to-use therapeutic food to give the children. If they can able to consume the adequate quantity as given in the book, they can treat at the home itself and followed by the RBSK team at the periphery level itself. These things I just want to add it up. Thank you, madam.
Thank you, Tenmuri. Thank you for joining.
The others, in case they want to add in or ask Rama madam or Dakshani madam or Tenmuri madam on anything, you're welcome. Anyone from the audience? Okay, ma'am, I think yours was explicit. So thanks a lot. In case they have anything, probably they can always get back to you on at any time. So that's not an issue at all with Rama madam. Thank you so much to Dakshani ma'am and Tenmuri ma'am. Thank you, Rama ma'am. Thanks a
Thank
lot.
you so much. Special thanks to university and to Daksh and Tenmuri. Thank you.
Thank you, ma'am. Thank you so much. Thanks to university also.
Bye.